In this video, we're going over what physical therapists need to know about our favorite knee injury, IT band pain. What's up, guys? Welcome to the Fitness Pain Free Show. I am Dan Pope. This is Kevin Coughlin. We are physical therapists. We summarize the literature, try to give you the most important points, add our opinion, expert opinion, some would say, and we try to help you out to become an amazing clinician. How are you today, Kevin?
Dude, I'm doing well. We've been talking knees all morning, which I love knees. So let's throw in some IT band pain into the mix as
Some say
well.
it's the superior joint.
It is a great joint.
Mhm. Yeah. All right, let's go straight into these learning points. We're going to go over the background of IT band. We're going to go over which population is most common in. We're going to go over anatomy, biomechanics, the mechanism of injury. We're going to go over predisposing risk factors, history taking for your patients, clinical presentation, diagnosis, differential diagnosis, as well as the natural history of ITB pain. And here's the thing. I took a lot of the information in this lecture from a few different papers, and probably the one that I took most of the information from was this study from Sports Med in 2022. It was titled The IT Band, a Complex Structure with Versatile Functions. Lead author was Hutchinson. And the other author on here of note is Rich Willie. Sorry to the other authors. You guys are all great. It's just I wanted to just talk about the lead author as well as Rich, because I have taken the majority of my knowledge about IT band from Rich Willie. Okay. This guy is amazing when it comes to running injuries in general. He's out in Missoula, Montana. He's a professor and researcher. And I basically just took his information. So if you want to dive deeper into IT band pain or just running injuries in general, I highly recommend Rich. He's phenomenal. Hopefully get into the podcast at some point. So if you're listening to this and you've listened to a lot of Rich, it's probably going to sound like I'm just stealing from Rich. It's because I am. He's really smart. He's helped us out. He's also sponsored this podcast today with his knowledge only, not with any monetary, right? He has no idea we're doing this right now. I'm just kidding. All right, let's get started. Let's start off with background and population. So IT band is the primary source of lateral knee pain in runners. So not the primary source of knee pain in runners. That would be patellofemoral pain. But for lateral knee pain, it's the primary source of pain. Okay. And it's the second most common form of knee pain next to patellofemoral pain or runner's knee, right? But ITB pain makes up 5 to 14% of running related injuries, depending on the study that you're looking at. And what's interesting about IT band pain, as opposed to patellofemoral pain, is that 50 to 81% of folks with ITB pain are males. So from a differential diagnosis perspective, spoiler alert, we'll go over that a little bit later. If you're looking at a female, probably more likely to have patellofemoral pain than someone who has knee pain and they're male and they're a runner, okay, off the bat. Which populations is this prominent in? It's mostly prominent in runners, okay, and this makes a lot of sense. So obviously runners, you'll see this, but also military, probably because they do a lot of running. You also might see this some in cycling and other athletes as well, but it's really most common in running related activities, right? These folks tend to have pain over the lateral femoral condyle, and I have an image here if you're looking at this on YouTube to kind of see where that is, down by the kneecap, right on the outside there. And essentially, these folks tend to have pain around 30 degrees of knee flexion. Why is that? I'll get to this a bit later, but largely ITB pain is a compressive issue. And when we get to about 30 degrees of knee flexion, we compress the IT band over fatty tissue that lives below the IT band. And that is highly innervated. And that's probably this primary source of pain. So around 30 degrees is kind of considered that impingement zone. So if you take the knee, if you think about a noble compression test, you're trying to push the IT band over that aspect and then bend and straighten the knee through that impingement zone and reproduce someone's symptoms, right? Largely, that's what we think is going on with ITB pain. Pardon the interruption, but I've got something I really think that you're going to love. It's an evidence-based guide to IT band pain. And you know it stinks. You have a patient that comes in, they have a pathology you haven't seen in a while, IT band pain, right? Pops up every once in a while. You don't remember how to treat it well. What does the evidence say? I don't remember. Well, now you don't have to fake it, because my promise to you is I want to catch you up to date on IT band pain in under 10 minutes. The evidence-based cheat sheet is a 5-page PDF, and we go over all things IT band pain related. background, population, biomechanics, anatomy, a mechanism of injury, diagnosis, differential diagnosis, treatments, and then natural history. Does this thing get better over the course of time? Does it revert to the mean? Well, you got to download it to find out. Best thing is that it's 100% free. So go ahead and click that link in the description, in the show notes. Download the cheat sheet and catch yourself up to date on IT band pain. Back to your video.
Yeah, so I too am a big fan of Rich Willie's, and a few months ago I took one of his online courses, Advanced Concepts in Running Injuries, and then it's kind of one of those things that like once you learn something new, you feel like you see it in the clinic more and more. Probably just something I was missing before, and I remember learning that, or I being surprised when I learned that it's the second most common form of knee pain. I feel like just the populations we see a lot of like meniscus injuries and intra-articular pathologies, but I do feel like now that I'm better educated on IT band pain, it is something I'm seeing a little bit more frequently in the runners I see. So, if you do see lateral knee pain, definitely have this on your radar as something that could be the source of pain. So, Dan will get into, how we diagnose it and that type of stuff, but just have it on your radar because it is pretty common. And I was surprised to learn that.
Yeah, what's funny is that I think when I graduated from PT school, I expected to see more of it, and then I didn't see a ton over the course of time, and I was a little surprised. But I think it is very specific to runners. If you work with a lot of runners, you may see it a little bit more. I have one on my schedule right now, so pretty interesting. Good that we kind of go through the literature. He said he's going to listen to this as well, so
Nice.
maybe we'll learn together and we'll help him out more so. All right, how about the anatomy of the IT band? Because understanding anatomy is important for kind of dispelling common misconceptions about ITB pain. And it's also really important. So the paper I was talking about previously with Hutchinson is that the way that we're going down the treatment rabbit hole for IT band is based on infactual information. And that's a problem. And we'll talk about why this is in a moment, but we need to keep in mind the anatomy and what's actually occurring from a mechanistic standpoint from creating IT band pain in order to do further research to kind of figure out best treatments and, the actual mechanism of injury. And the anatomy is very relevant. So we'll go over that briefly. So first I want to talk about the IT band attachments. If you're watching this on YouTube, you can see the image here. If not, at some point, maybe pull over and bring up YouTube while you're driving. Just kidding. Don't do that. But at some point, you want to try to look at this. So the IT band has a bunch of attachments. So all the way up at the top at the iliac crest. It also attaches to the TFL, which is really important to understand. It attaches to the glute max, the superior portion of the glute max, not the inferior, potentially relevant. It's important to understand it does not attach to the glute medius, right? So when you're choosing exercises, if you're targeting the glute medius, I don't think that's a bad thing, but keep in mind, you're probably not putting strain on the IT band when you do that. It also attaches to the lateral femoral condyle. So before it attaches below the knee joint, it actually attaches above the knee joint. It's interesting because it has a shared attachment with the LCL. I'm currently dealing with an LCL injury. And if I go into some of these test positions we'll talk about later, I feel a little clicking. And I think I have a little bit of IT band irritation associated with the LCL injury. It's kind of interesting. What's also cool is that the IT band also attaches to the patellofemoral joint via the lateral retinaculum, which is kind of interesting. And then it attaches below the knee joint on the tibia on Gerdy's tubercle. Everyone's favorite tubercle, Gerdy's tubercle. Sorry, that was bad. So interesting. It attaches to the lateral femoral condyle as well as patella, right? And the thought process now, and we used to think the IT band was a friction syndrome. You ran, and essentially the IT band is rubbing over the side of the knee back and forth over and over again. And that's creating irritation on the side of the knee of that kind of fatty substance, right? We talked about earlier. However, we've now found from cadaveric studies that the IT band is adhered pretty dang well to the side of the femur. So essentially, when you are running and flexing the knee, it's not really rubbing over that area back and forth, again, because the IT band is tethered down. So what you're seeing more in the literature now is that we're not considering this so much of a friction syndrome, but more of a compressive syndrome. Any thoughts there, Kevin?
Yeah, I agree with you. I think understanding the anatomy is important for understanding the treatment that we'll get into talking about. So I think that was a good background of the anatomy. And that last point, I think did kind of shift a little bit how we think about treating IT band pain versus, that friction syndrome versus more of the compression syndrome. So, I think that's important to understand. And I do think Gertie's tubercle is a really cool name.
Hmm.
Imagine if you found something and it was Pope's tubercle.
Oh,
Like, I know. Why can't, I got to discover a tubercle somewhere so I
I
can
know.
get, but Gertie's is a cool name.
It's not bad. Fun fact, we had llamas growing up, one of which was named Gertie.
Nice.
And she was a mean llama. She loves spitting all over you. You guys don't really care about that. Let's move on to the IT band. We'll talk about biomechanics. So what the heck is the function of the IT band? The IT band is really interesting from kind of an evolutionary standpoint. It's unique to humans. So we're the only mammals that have one. Kevin actually has no IT bands. He's an anomaly. Just kidding. He has two. And the idea is that we evolved this to support upright walking. And it seems, and these are all kind of theories, is that it's a frontal plane stabilizer of the hip and the knee. And what it does do, and this is not a theory, is it resists various forces on the knee. So this becomes relevant from a treatment perspective, and we'll talk about this a little bit later. It also stores and releases elastic energy during gait and running. So the Achilles, I think, is 35 to 40% of running. The elastic storage is occurring in the Achilles. About 5% actually occurs in the IT band. So you can kind of think of it a little bit like a tendon. I know that Rich really always said, if you treat this kind of like a tendon problem, you'll probably have some good success with it. So the research is very sparse in terms of treatments. We'll talk about this in the next podcast. But yeah, we're thinking of it kind of like a tendon. Any thoughts on that, Kevin?
Yeah, just briefly on the anatomy too. I think what I've found anecdotally, and I think I've heard Rich say this either in that course or in one of his papers. I think when we think of like an Osgood Schlatters type thing, you do see the hypertrophy around the tibia tubercle. And I do think with people who are using their IT band a lot, which are runners, you're utilizing the elastic recoil energy of the IT band, is you do see a little thickening around Gertie's tubercle, perhaps. So just something to keep in mind. It doesn't mean anything bad, but I think anatomy wise, it can help you locate it. It can be a little prominent in people who use it a lot. And maybe that's just kind of like that Wolf's Law, right? Like it's adapting to the stresses applied over time. More people who are doing sports that are really resisting kind of a varus force. So just something to keep in mind.
I have an oddly prominent IT band myself. I don't think that's because I'm good at sports at all, but just born with it, probably. All right. So, how is the IT band involved with running? Because runners, obviously, that's where we see most of this ITB pain. So, understanding the biomechanics becomes really important in running. So, I have a picture of a lovely lady here running. And essentially, as we're running and our leg swings behind us, right? So, think about going from kind of mid stands to toe off. Your TFL muscle is loaded eccentrically. If you have a combination of hip extension and knee flexion, this will strain the IT band and can produce pain. So kind of interesting, but in folks that have ITB pain, oftentimes it's that trail leg that ends up hurting, right? And the other piece is that, and this becomes relevant from a diagnostic perspective too, is that running downhill might cause more issue just because we're going to have more eccentric loading in the TFL because we're going downhill. Same thing happens when you're going downstairs. And folks have a really aggravated ITB band, or excuse me, have a lot of pain in the IT band region where it inserts. Sorry, there's a lot of words there. And I got to stop going back and forth between iliotibial band and I don't know. So when folks that have ITB pain, when they go downstairs, this can be particularly provocative as well. From a running perspective, some things that can also increase strain on the IT band are going to be running with a narrow stance. So think about running a trail, a single track trail, where you essentially have to make sure you're kind of running a tightrope. You're having more hip adduction as a result. And then hip drop, so contralateral hip drop. And again, if you're watching this via YouTube, you'll see this. But if I'm hip dropping on one side, that can also increase IT band strain, right? And again, from an energy storage and release perspective, the IT band actually contributes 5% of energy storage and release while running, whereas Achilles is going to contribute 35 to 40%. So the Achilles does the lion's, share of the work, but the IT band is also doing quite a bit of work too. And the last piece to keep in mind is that higher speed running also increases strain on the area too. So if you have a patient that has ITB pain, they may tell you, if I run faster, I have more pain, right? Any thoughts there, Kevin?
Yeah, I think that type of those biomechanics are important to know and make sense. I think because what you'll hear from the patient is this could be more common in trail runners for sure. So when you are running on a narrow trail, you have a more obviously narrow step pattern, and we know that could increase strain through the IT band. And then the other thing that you had mentioned is that if you do see that pelvic drop, that could also increase IT band strain, running faster, running downhill. So these are important things to understand, because it will get into the treatment. It allows us to modify certain things without having to take running out completely. So we have to understand. I think if you're treating runners, there are a lot of different types of running. Like without getting too far off track, running uphill puts a little more stress to the Achilles tendon. Running downhill puts a little more stress to the IT band and the patellar tendon. So there are ways that we can modify training to allow our runners to keep running without having to just cut running out completely. So keep those biomechanics in mind.
Yeah, the other biomechanical thing I'm sure Kevin's going to cover eventually is cadence. So if you have a slower cadence, generally speaking, it's a little more stress through the ITB band as well. ITBB, there's too many B's there. The IT band. I'm doing a terrible job this podcast. Let's move on. Okay, so from a mechanism injury standpoint, what's kind of going on? We talked about this a little bit in the background, but essentially we're getting compression of the fatty tissue under the IT band when we run. This is largely going to be happening around 30 degrees of knee flexion. And you're going to have tension of the IT band over the lateral femoral condyle, squishes that fatty tissue. And essentially the idea is that the tissue might just be unprepared for the work you're trying to throw at it. And essentially over the course of time, you end up getting pain of that tissue. And sometimes some clicking associated with that. And Kevin and I were talking, like, why the heck does it start clicking? I wasn't really able to find a whole lot of information as to why this happens, but I certainly see it. And the patient I have right now, his knee does click, but I'm assuming it's going right over that fatty tissue. But the other thing you'll hear patients say is that didn't click before, started clicking now. So I wonder if there's some change in that fatty tissue potentially, although I didn't find much of that. So kind of brings us to our next conclusion, that the mechanism of injury is kind of wrapped up in a load management problem. So what you might hear for some of your patients is that they had a sudden increase in their training volume. Maybe they increased their speed recently. They did more downhill running or more trail running in general. So it could be because they have a narrow base support, or because when you do trail running in the woods or running up and down mountains, you're doing more hills, right? So going down hills more. These may be some of the things that set off IT band pain. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms, or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. All right, so how about from a diagnostic perspective, what are patients going to say to you subjectively? So I think the first giveaway is that they've got lateral knee pain on the side of their knee, okay? In terms of where, because there's a couple different types of lateral knee pain, pain is approximately 2 to 3 centimeters proximal to the lateral tibiofemoral joint line on the lateral femoral condyle. A lot of words there. The onset of pain is often insidious in nature, meaning that it doesn't seem like there is one inciting event, just kind of gradually comes on over the course of time. Although I have had some patients where it does seem to come on kind of suddenly, running, all of a sudden, ooh, that's a sharp pain. I need to stop, right? It's often preceded by a recent spike in running loads, usually consisting of an increased running distance or increased volume of downhill running, particularly. Patients may report pain reproduction in their stance side limb during stair descent. So like we talked about before, the legs going behind them, the TFL is active, eccentrically, creating some pain. The hip extensions coupled with knee flexion as the TFL musculature contracts eccentrically to assist in lower limb control. And then running is usually when this occurs, particularly downhill or fast running, may also exacerbate IT band syndrome or IT band pain. We're potentially changing that name soon, so I'll be careful about how I use it. And these are some of the things you may be hearing from your patients. Any other wild and crazy things you hear from your patients, Kevin, about ITB pain?
Yeah, no, I think that was pretty good. I think I don't know if I told you this. Dominique, my wife, has IT band pain right now,
Ooh.
and it stemmed from a marathon that she had ran at the end of May. And
Mm.
really, I think interesting. I think this can happen with tendons in general, but no tendon pain throughout training. And then the day of the marathon, it's like no matter how much you prepare, you're running faster for longer than you ever have. And this particular marathon course was very hilly, a lot of particularly a lot of up and down hills. So that mechanism, the pain location is what you had said. It's really, right over that femoral condyle. And just, yeah, interesting. A lot of those similar things hurt, like going downstairs. So I think that shows to me that, this can be kind of insidious onset of a, gradual training, increasing stress, and pain kind of comes out of nowhere. But I do think sometimes we do see these like massive training sessions that can kind of spark things as well. So you might see a little bit of both, but I do think, it probably has to be a pretty novel stress to cause some IT band pain that's going to last for quite a while. So
Yeah.
just interesting.
All right. How about from an objective sense? Any tests you definitely need to do? So there's a couple that you'll see in our medical literature. I think the first of which is going to be the Noble's kind of compression test. So your patient is in supine on their back, bending the knee up, and the therapist places manual pressure to the patient's lateral knee, again, 1 to 2 centimeters proximal to the lateral femoral condyle, as the knee is passively extended through a range of motion from about 60 degrees to full knee extension. Essentially, you're trying to reproduce that same mechanism of injury, see if that produces their pain. You can also do this in sideline with the hip held into extension and internal rotation. This is a modified Noble test. The idea is that this position, as we described, is going to load up that TFL a little bit more, maybe reproduces their pain more so than a standard Noble's test. So here's the thing. We don't have sensitivities or specificities on these tests simply due to a lack of a gold standard, which means that we don't have an MRI or arthroscopy or some sort of image that would tell us that a person definitely has IT band syndrome. So we can't even create a sensitivity or a specificity, right? So we're not really sure how good these tests actually are. It's kind of the best of what we have right now. So we can use a combination of these kind of subjective and objective tests to try to get an idea of what the patient has. How about the Ober's test? Are you an Ober's guy, Kevin?
Dude, right now that's the only test I use for most things. So
well,
I don't know.
that's the problem.
Should I use it?
Yes. Just kidding. Ober's test is not a good test for IT band pain. A couple of reasons why. So it was a cool study. This was in cadavers. Essentially what they did was they tested in an Ober position how much hip adduction the cadaver had. And then they went ahead and cut that IT band and measured it again. And what do you think they found?
It probably looked the same.
It looked the same. So no change, right? When they cut the glute medius and minimus, they had an appreciable change, and they had the most change when they cut the hip capsule. So essentially, the Ober's is not a good test of IT band stiffness. And here's the other piece. IT band stiffness, and this is measured via shear wave elastography ultrasound. Had to learn more about that. Essentially, they have an ultrasound machine that bounces off of the IT band and gives you information about how stiff that particular substance is, right? And they use that to measure stiffness like the Achilles tendon, IT band, so on and so forth. And what they find is that IT band stiffness increases as ITB pain subsides. And this potentially alludes to stiffness being beneficial, meaning that we don't necessarily want to reduce stiffness. And you can actually look at studies where they foam roll the IT band and it shows that doesn't change stiffness, right? And we may want to have this stiffness, and we probably can't stretch this via doing a whole bunch of IT band stretches, just because if we do these ITB stretches, we're probably stretching glute med, glute min, as well as the capsule, not the IT band. And we probably at least want or think that stiffness is important, so we don't want to loosen it, right? So you can kind of see how, basically guys like Rich Willie are so adamant about teaching people about this, because currently a lot of folks think we have to foam roll it, we have to stretch it, when in reality, these may be interventions that help reduce pain. But if you think from a mechanism of injury standpoint, it's a little backwards, right? Yeah, enough about that. All right, from an objective standpoint, should you do strength testing? I think so. Got a little bit of research to show that patients with ITB pain present with reduced hip abduction strength. And here's the thing. This is kind of the same as patellofemoral pain. They've also studied that hip abduction strength is not a risk factor for ITB pain, but weakness, it kind of appears afterwards. I will say that when I did my lit review, you actually will find a paper or two that will show weakness potentially being a risk factor for ITB pain, but that's not the same across the board. It does seem, based on the study that you read, that having this weakness is a result of having the pain and not necessarily something that causes it, right? Although we haven't parsed that out completely. How about from a gait analysis perspective? Should we be looking at gait and then giving specific recommendations to change technique, or are there certain things that we see that can help us with our diagnosis? So this is based on conflicting evidence, but patients may run with increased hip internal rotation adduction, right? So they may have a little more internal rotation of that hip, more adduction, and that could kind of back up the idea of having a narrow stance or having a lot of hip drop being something that may cause some problems in folks that eventually get ITB pain. However, I looked through probably about 4 or 5 studies, and there's a lot of conflicting evidence, and it was based on weak evidence. And eventually my thought was like, I think I've done enough looking. I think that this is kind of weak evidence, and I don't know that I can kind of lay my hat on that, put my shingle on that, whatever that saying is. I don't think the evidence is strong enough for us to say, like, yeah, if you run kind of funky, you're going to end up with ITB pain, right? Just keep in mind that's going to be conflicting research, different from studies, different from males to females. It's very confusing. I do recommend you got to go in there and get your hands dirty, try to read some of those papers, get a little confused, just like I do. I think that gives you a little bit of an understanding of how complicated the situation is. Maybe less likely to use black and white statements like the way you're running is causing this problem, because we know that's not always the case, right? So now the interesting factoid I came across is that those with ITB pain showed a reduction in adduction, that's hip adduction, with prolonged runs And the thought is, there's several studies that show this, by the way, that this is potentially a strategy to reduce ITB pain as you progress into the run. So generally, the longer you run, the more pain that you end up getting. These folks are starting to run a little bit differently, potentially to reduce pain to protect that area, right? And lastly, should we be looking at imaging to help to rule in this condition? Largely, no. It doesn't give us great information. So I wouldn't say that the patient comes in and it seems like they have ITB pain. Don't send them back to the doctor to get imaging. It's really not going to change things too much. I just spit out a lot there, Kevin. Do you have any particular thoughts on that?
Yeah, I think I came across a lot of the same types of things that you had just mentioned. I think in terms of diagnosis, the Noble compression test, like you said, it doesn't have any sensitivity or specificity because we don't have a gold standard to compare it to. But I do kind of look at that like palpating the patellar tendon and trying to rule that in. It does seem like to me, if with a positive test, I can kind of, that's replicating their pain, kind of feel like this is another check in the box of what might be going on. But if it's negative, it doesn't totally rule it out for me, is how I think about it. Anyway, it's a piece of the puzzle. And then in terms of another diagnostic test that I think that I've come across that seems to be helpful is that you had talked about what loads the specifically TFL, but the IT band eccentrically is hip extension with knee flexion. So if you picture like a step down test, if you perform that with your trunk leaning backwards, so you are in some hip extension and then you do a step down, that seems like it can really elicit IT band symptoms. And it's something Rich talks about in that running course that I had mentioned earlier. And I've used it on a couple patients with suspected IT band pain, and it does seem like it does elicit their familiar symptom. So it's something that I've been using. I think is a pretty good test, but I don't think there's any specificity or sensitivity with it yet as well. But yeah, those are just a couple things I wanted to add.
Now, Rich is a smart guy, huh?
Yeah, got to get him on
Dude.
the potty.
Yeah. Smart. All right, cool. Differential diagnosis. How do you make sure you're not missing other different types of pathologies need to be treated a bit differently? So patellofemoral pain is a big one. So you can look into things like deep squats. They usually have anterior knee pain, and then they're more likely female than male. Lateral meniscus is a big one. I've actually missed this in the past myself. You can assess this via range of motion, end range, extension, and flexion. Is there any joint line tenderness, any swelling? Is there a subjective complaints of someone kind of twisting, falling, having kind of an inciting event that was different than the inciting event for, let's say, ITB pan, which is more just straight plain running, maybe trail running, so on and so forth. Lateral femoral stress fracture, an important one. You can do something like a fulcrum test, high sensitivity to that. I'll put out a video of that at some point in the future. Stay tuned, right? Another thing that Rich has said is that these folks tend to have some night pain. These folks tend not to warm up with running as well. So some things to think about. Gluteal tendinopathy sometimes masquerades as ITB pain. People kind of point to their IT band hurting. Oftentimes that's actually coming from the hip. You can do some sideline abduction tests. I like to do sideline abduction tests with the hip in adduction. Got these tests from Allison Grimaldi. I think they're quite good. Then lumbar radicular pain, obviously very different disorder, but sometimes also will radiate pain in that region. You can do things like a slump test or a straight leg raise test to try to rule that in or rule that out. And lastly, natural history. So essentially, does ITB pain just get better over the course of time without any intervention? Something like patellofemoral pain does not revert to the mean very well at all. We know that if you get a patellofemoral pain, there's a really good chance, A, it doesn't go away, and then B, it just persists for years and years. Same thing kind of goes for patellar tendinopathy. That can be super stubborn, very recalcitrant. Is ITB pain something that we don't have to worry about so much? Is it kind of like cervical radiculopathy? It tends to kind of get better over the course of time. Well, this was a cool study. It was called the Run Clever study. And essentially, initially, they were looking at data in runners to see if running volume or running intensity correlated with injury, right? And it didn't, but that's not what we're going to talk about today. In this study, they gathered a bunch of data. The data was used to try to figure out the natural history or natural course of different running-related injuries. So essentially, it was a 24-week follow-up study. They're looking at recreational runners. And as they're running, I think 32% of all runners in this study got some sort of injury over the course of the study design, 24 weeks. And They basically diagnosed the runny injuries when they occurred, but they didn't give them any treatment. And they were free to get treatment if they wanted to or just not, right? So again, this could be controlled a little bit better because I'm guessing some of those patients actually got treatment, sought out some treatment, and some patients didn't, right? So who knows if some of these folks potentially got better faster than others because they got treatment. And essentially, they followed up and they were trying to determine when these patients had a complete symptom resolution. Essentially, when do they get to the point where they don't feel this thing anymore at all, right? And for IT band pain, this average was 56 days, which is kind of cool. So essentially, this is good information you can use for patients. They're like, well, how long is this going to take to get better? Well, at least in this study, the average was 56 days, right? And some people obviously got better faster, some a little slower. One of the major limitations of this study is that those who did not heal during the study duration were excluded. So essentially, if your pain took longer than 24 weeks to resolve, they excluded you from the calculation. So that's a big problem because I know there are some ITB patients that didn't get better over the course of this study and they were excluded. So if they kept those patients and they kind of studied these patients further out, this average would obviously go up. It would take a little bit longer, right? But at least in my mind, I thought this was a really cool study because when runners come in with any sort of pain, and they studied a whole bunch of different types of pain, plantar fasciitis, Achilles, shin splints, meniscus injuries, it gives you a bit of an average and you can tell your patients. Obviously, it's always going to be variable, but it does seem two things. A, that it has a natural history, seems to get better over the course of time with or without treatment. And B, we have an idea of about how long that takes, right? So pretty cool stuff. Any thoughts on that, Kevin?
Yeah, that's really cool study. I think with that IT band duration, I think what you had said sounds about right from what I see is that, someone, I think it depends how long it's been going on. But it is one of those ones too that, we're probably not getting better in a week or so. We have to kind of manage expectations with our treatment and just, be prepared to continue to rehab this thing for a little bit of time. But I think there are a lot of ways we can manage it, which we'll definitely talk about in the future.
Okay, so now you have some background information about IT band pain, which is the second most common knee pain injury in runners. You probably need to know more about the number one, in my heart as well, form of knee pain in runners, and that's runner's knee or good old patellofemoral pain. Well, Kevin and I, we have an amazing video for you, and we are going to place this video directly above Kevin's head right now. Yep. Whoop. I think I see it. Oh, there it is. Great. So go ahead and click on that link, and we're going to go over what physical therapists need to know about patellofemoral pain, and I will see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.